Good evening, everyone, and welcome to our China-Mexico International Webinar on ESD, Endoscopic Submucosal Dissection. Thank you all for taking the time to join us this evening. I'm Guido Grajales, your moderator for today's session. We're honored to have with us our special guest, Dr. Alberto Baptista from Venezuela, a renowned expert in Latin America, and two distinguished endoscopy specialists from China who will share cutting-edge insights into endoscopic procedures. Today's webinar has two key components. First, Dr. Catherine Chen will present special clinical cases in ESD. Then, Dr. Mei Liu will demonstrate a live lower GI endoscopic procedure where you'll see the latest technology from Linmo Medical in action. Now, let's warmly welcome all our guests. First, please join me in welcoming Dr. Kechuan Chen, who will share fascinating ESD cases with us. Dr. Chen is the Director of Department of Gastroenterology, First Affiliated Hospital of Guangzhou Medical University. Dr. Chen, the floor is yours. We look forward to hearing about your clinical experiences.
Okay, thank you, Dr. Guido. Now I share my PPT. Sorry. Now you can see my PPT, Dr. Guido?
Yes.
Yes, now I start.
Perfect.
Good evening, colleague in gastrointestinal endoscopy from Mexico. Let me share some particular memorable case I encountered while I perform ESD. First, let me review the indication for esophageal ESD. Why are mainly T1A esophageal cancer with tumor confined to the epithelium or laminium porium mucosa. The first case is a 15-year-old male. The character of the lesion is that it's very small and located on the left wall of the esophageal segment, an area where it is very easy to miss the diagnosis. We use the incision knife to mark around the lesion at approximately 0.5 millimeters, then perform a submucosal injection. After that, we use the incision knife to completely reset the lesion. The final pathology indicate esophageal carcinoma in still with no recession. Tumor found at the lateral and basal margins. This case is a 69-year-old female. The key point is that only one lesion was found at an external hospital. Later, using gastroscopy, we discovered 3 lesions located in the upper, middle, and lower segments of the esophagus. We sequence mark the lesion and perform ESD treatment using a knife. Finally, all lesions were completely reset. The patient has now been followed up for over 2 years with no recurrence of the lesion or the occurrence of new lesions. The final 3 lesions were reset, and the pathology indicate early stage esophageal cancer in all of them, including 1 case of carcinoma in stem, 1 case of mild dysplasia, and 1 case of intramucosal carcinoma. And the patient three is the patient is a 7 years old male. The main lesion was located at esophageal inlet, making ESD treatment particularly challenging. And then finally, the procedure was performed with a senior physician using ESD technique, with the lesion reset in two pieces. However, the lesion was completely reset, and the two pieces was successfully combined to form a single specimen. During the follow-up period, the patient developed a mild esophageal structure 3 months after the surgery, which was a sequence managed with dilation. Over more than 2 years of follow-up, there has been no evidence of recurrence. The final philologist also confirmed the lesion to be an esophageal squamous cell carcinoma in situ. This case highlights that its ESD at the esophageal inlet is extremely challenging. However, it also demonstrates that as long as the lesion can be completely reset, even if it requires specimen resection, a curve-active outcome can still be achieved. Of course, this relies on an experienced senior physician overseeing the quality of the procedure. And the patient was a 72-year-old male with a lesion located in the lower esophageal, especially at the esophageal gastric junction. Lesions in this area have two notable characters. First, they tend to be small and therefore easily missed during round examination. Second, if overlooked, the reach of this region can facilitate deep submucosal invasion or even distant metastasis. Therefore, we must maintain a high index of suspicion for earlier stage cancer at the esophageal gastric junction. After the dissection, the lesion was treated with ESD, achieving resection. Follow-up for more than 2 years showed no signs of recurrence, marking this as an other successful case of curative resection. The final pathology of this patient also indicate high grade intraepithelial nephroplasia of the gastric cardia, identified as a well different tuber adenocarcinoma. And next, let's discuss the indication for ESD in early gastric cancer, especially if the lesion has no answer and if it's of well differentiated type, it can be treated with ESD. Additionally, if it is an undifferentiated type, the lesion size must be less than or equal to 2 cm. If the earlier gastric cancer lesion has answered, then its size must be less than or equal to 3 cm. And let me share the case. And the first case is a 56-year-old male. A polyline lesion was found in the stomach wall of the gastric fund and an Esker hospital, where it was initially considered a polyp. However, after we performed a gastric examination, we observed that the lesion had a relatively clear boundary with dilation of the ganglion ducts in the microsurface structure. Additionally, there were suspicious finding of the tumor-related microvascular change and density. Finally, we conduct that it might be not a simple polyp, but rather than an early gastric cancer. Therefore, we apply ESD achieve recession deletion. Finally, the physiology of this lesion indicate gastric carcinoma of the folded gland type with an invasive dip exceeding 500 and one focus of small vessel invase was observed. However, the patient refused additional surgery. As of now, it has been followed up for more than 3 years without any sign of recurrence. This also highlights that relative low malignant potential characters of gastric adenocarcinoma of the folding gland types. Most of the cases were typically encountered out of the differentiated type. If an undifferentiated type of the gastric cancer can be detected and treated endoscopically, the benefit to the patient is maximized. However, this must, of course, adhere to indication for endoscopy ESD. Take this patient, for example, a 61-year-old male with a reddish lesion found in the gastric angle. Using magnifying endoscopy, we observed that the local structure had disappeared, with while some tumor-related microstructure were still visible. And finally, we reset the lesion using ESD. After resection, you observe that particular grade light vessel with which suggests a moderate differential adenocarcinoma structure. Additionally, in some cases, the glandular duct had completely disappeared, revealed irregular tumor linear vessel, which indicate a potential modified differential type with focal port differentiated earlier gastric cancer. Finally, the physiology also indicated a moderate to poor differentiated carcinoma. However, the cancer tissue did not invade the muscular mucosa, and both linear and basal measurements were negative for carcinoma. The patient have been followed up for more than 2 years with no sign of tumor recurrence. This represents a successful cure case earlier gastric cancer. And this case is similar to last case, and the change is also similar. We also use the ESD to reset the lesion. The lesion in the gas come forward. Also, the physiology also confirmed to be a moderate or poor differentiated tumor adenocarcinoma. And the case is a 62-year-old male. Also, we found a change in the subvessel and the microstructure. Finally, we use ESD to reset the lesion. The physiology was considered consistent with our endoscopy diagnosis. The lesion was moderately differentiated tubular adenocarcinoma with approximately 30% containing poor differentiated tumor adenocarcinoma components. And the last case also, but the character of this case is too lesioned, and we communicate with the patient. You also want to the ESD to reset the lesion. You also reset the lesion. It also indicate that the signature renal cell carcinoma accounting for 19.5% and poor differentiated carcinoma accounted for 5%. However, the cancer tissue was mainly located in the laminar poria mucosa with no vascular or permeable invasion observed. The patient was also be followed up for more than 2 years with no sign of tumor recurrence. And the two lesions, just like the esophageal, may be occurred in the stomach. We must might notice. And last is the indication of colon cancer. We also recession and the guideline for the earlier colon cancer recession. And most case is in the rectum. Rectum, we use the ESD, the patient will get more benefit. Oh, I can see that this 35 years old. This case is involving a 53 years old female during the colon endoscopy with we observed 2A light lesion near the anus, especially on the anus side of the rectum. After analyzed, we use ESD to recess the lesion. And the theology is the high-grade intraphyllotic neophylis in the glandular epitheliums. And after the final lesion, we found 76 years old female. Also, we use ESD to cut the lesion because, and we also tell the patient many change the position of the change the position and help me finish the ESD procedure. And sometimes we use the something to help me to give me a very good scene, and we can use the use the tip to give a very good season that we can use the knife to cut the lesion easily. And this is 68 years old male with a history of lung transplant surgery. A large nodal evaluation was found in the rectum, surrounded by the small nodular lesion. Using magnifying endoscopy, we observed that the lesion and suspect it might have a relative deep submucosal invasion. However, the patient declined surgeon intervention, so we proceed with ESD technique to perform a complete in colon resection of the lesion. The follower later revealed this lesion to be a moderate differentiate adenocarcinoma with no vascular invasion or other invasion identified. However, the depth of the submucosal invasion exceeded 1,000 unit, which is beyond the observed indication, but may still be considered within expanded indication for colon ESD. Although the patient declined surgeon intervention, we has been followed up for over 3 years while continuous taking anti-rejection medication, and there has been no recurrence of the tumor. This case demonstrates that for some early stage colon rectal cancer, performing ESD may offer greater benefit to the patient. Therefore, we must consider individualized treatment approach to maximize the patient outcomes. And this the food things recession of the lesion. And this patient now the physiology is not the cancer, and patient avoid the surgery treatment. And now this patient is a 36 years old female with submucosal evaluation lip appendix office. We perform an endoscopy ultrasound, which suggests that potential gastrointestinal structural tumor with extraluminal growth. The patient wish to avoid surgery and require endoscopic resection. So we proceed with ESD. However, during the dissection proceed, no distinct mass was visible, although we had already performed through the appendicial office. Therefore, we had no perform a complete endoscopic resection of the appendix. After the resection, we close the mucosal defect with the clips. Ultimately, the physiology of the appendix did not reveal a GIST, but rather indicate chronic appendicitis. And thank you, everyone. This is our gastrointestinal endoscopy center. We are equipped with the C-arm for ERCP and EUS procedure. Additionally, we have ventilator available, allowing us to perform ESD procedure requiring touching intubation within our own endoscopy center. We welcome all experts to visit and provide guidelines for us. Thank you.
Thank you, Dr. Chen, for that excellent presentation and valuable clinical insights. These special cases truly demonstrate the complexity and elegance of ESD therapy. Before we move to our exciting live procedure, let's watch a brief introduction video showcasing the advanced technology from Linmo Medical. Welcome back to our webinar. Now we're entering the most exciting part of today's session, the live lower GI endoscopic procedure. Please welcome Dr. Mei Liu, who will demonstrate live ESD procedure for us. Dr. Mei Liu is the Director of Department of Gastroenterology, Tongji Hospital, Tongji Medical College, Washington University of Science and Technology, and she's Vice Chair of ESD Study Group, Committee of Tumor Endoscopy, Chinese Anti-Cancer Association. Guests and viewers are welcome to ask clinical questions or technical inquiries at any time. Dr. Mei Liu, please begin your surgical demonstration. Dr. Baptista and myself will interact with you throughout the procedure.
我知道。好，标本呢？我的标本去哪了？到前面去了。 Okay, it's my turn right now. Good morning, everyone. Can you hear me?
Yes, we can hear you.
Okay. Good morning. My name is Mei Liu, and I work in Tongji Hospital in Wuhan, China. It's my honor to have this chance to share a demo case with you guys. And let me show you. This is a female case, female of 52 years old, and at regular colonoscope detection in outpatient department, we found two lesions in her colon. And the first is a very small polyp. It's around 1 centimeter size. I just cut it to use the snare. And this is the second one. You see another polyp, and it looks like the size is a little bit large. And so I will use the snare to cut it. And first I will inject saline at the bottom of the lesion. Okay. 好，针收回来，应该是没打进去。再来，好，够了，够了，够了，不打了，拿全套来吧。
Hello, Dr.
Hi,
Meliu.
good morning. Good morning. So after I cut this polyps, I will move to the third lesion. There's a AST at the rectum. So just wait a minute. Let me have a chance to get rid of the polyp first. You can take on the soya. 好，再来，再来，张开。好，圈套先丢开，我们换个方向。好，从这里去。哎，对。好，先收。好，稍微多了一点，往回来一点。OK，收收。我起来啊，拧上去的啊。OK， let me check it. Is there any possibility of bleeding?
Dr. May, can you hear me?
Yes.
What kind of energy are you using? It's a monopolar coagulation?
This is I used a colonoscope from a Lingmo company, which is a Chinese company, and I just use a regular colonoscope to treat this case. And then I will show you the AST at the rectum. At the beginning, we need to wash a little bit to confirm the to confirm the good vision of this lesion, and we need to observe the surface of the lesion to make sure it is a suitable case for the ESD. Let me show you. So, at the surface of the lesion, we will see very regular microtexture, and the vessel structure looks regular. So I think this just is an adenoma. So this is a very good case or suitable case for ESD. And the location of this lesion is at the rectum. Let me see. Is about 5 centimeter, and the size of the lesion, I think, at the beginning we report the lesion, the size of the lesion is about 2 to 3 centimeter, but and now I think is it's around 5 to 6 centimeter. So before we perform the ESD, we will identify which side is the gravity side. So after we spray the water, we will see most part of the lesion is gravity upward side. So we don't to we needn't to change patient's posture at the beginning. And this is a large LST. For the LST in the of colon or rectum, we don't need to marking the lateral border of the lesion, because it's very easy to identify the border between the lesion and the normal mucosa. So we can begin to make a submucosal injection. Okay. I will choose to beginning the section from oral side first. Okay. Especially for the large lesion. I think that's a good choice.
Dr. Meliu,
Yeah.
what type of lifting solution do you use?
Just use a saline.
Just saline. Great, thank you.
Yes. And the saline, I mixed with methylene blue. So you will see the color is a little bit blue, because the color can help us to identify the submucosal layer and the muscle layer. And I use the dual knife.
Dr. Liu,
Yes.
how do you decide how much margin are you doing the incision around the lesion? What is the margin you are trying to take to assure the resection will be with free margins?
Okay. At the first, for the colon lesions, it's very easy to identify the border between the lesion and the normal mucus. And you will see it's about less 0.5 centimeter. I think 0.5 centimeter is better because after cutting, you with the mucosa uh will a little bit uh, pull back. So after we finish the ESD, we need to fix the spacement. So if the length around the lesion is too small, it's very difficult to fix the lesion. Use the spine.
Okay, and what kind of energy are you using? You are using endocut?
Yes,
And
endocut Q.
what
Endocut
settings?
Q. I used
Okay.
223. 223.
Okay.
So effect 2 and 223. And I used Swift calculation. I used Swift calculation 240.
Great, thank you.
It's my pleasure. 好，拜拜。打打。
Do you
好。
plan, Dr. Liu, to make a circumferential incision? Or do you
Yes.
plan to make like a pocket?
For the lesion is not too large, which is not so large. Okay. We may use we may choose the partial circumference mucosal dissection, but for the large lesion, I prefer to finish the circumferential dissection first. That's because if the lesion is too large, if we choose partial circumferential mucosa dissection, and after the submucosal dissection, the lesion will be very heavy, and it's very difficult to find the border between the lesion and the normal mucosa because of the gravity.
Okay, yeah.
Okay, there's a very small bleeding here, and we try to use the knife to calculate in the first. 倒回来，倒回来。Okay, I don't think it's necessary to make a calculation here. The bleeding is stopped already. 好，知道。好，倒回。Okay, 知道。好，就是。
Dr. Liu, do you always use a colonoscope for the ESD and rectal lesions, or sometimes you use a gastroscope?
Usually I will choose the knife first. I seldom use the forceps.再来，把下面打完。是这个地方在出压抑。So, the bleeding again. So I use the cap just to press the vessel a little bit. Okay.
A question from our audience, Dr. Liu. What size of knife are you using right now? Is that the 1.5 dual knife?
I
Two.
seldom use 1.5.
Okay.
Yes. Because I
So it's a
think the
2 millimeter.
1.5, yes, 2 millimeter. 1.5 is too short for me.
Okay.
Dr. Liu, this system from Limo has a special characteristic for helping to identify the source of bleeding?
Yes. There's sorry. I need to calculate the bleeding spot.
Sure.
Just wait me a little. Wait several minutes.
Sure.
八头十。你们临摹有那个功能吗？就这个。Okay. I will show you. 这叫什么功能来着？不是英文叫啥？你们的称谓叫什么？你们的缩写叫什么？不知道。DHI. Okay. I will show you the DHI model. So at this background, 稍往前推一点。The blood looks yellow, and we will see the bleeding spot very easy and clear. Eh, 怎么样回正常来着？白光怎么回？我要回白光。哪是2？这怎么回不去了？这是白光。还有哪里粗啊？
Dr. Liu, there's a tendency in many countries to prefer underwater resection procedures like EMR, underwater EMR or underwater ESD. Do you have you started doing underwater ESD yourself?
I seldom use underwater ESD. I prefer the ESD with the traction. I think that will be more easier and safe. I will show you next. So first, I finished the circumferential mucosal dissection. You will see. And now I will repeat the submucosal injection. The submucosal injection is a very important steps for the ESD. Okay.
Dr. Liu, is there any limit for the injection amount, the amount of the injection you can use?
I don't think there's a limitation for the volume of the injection solution. I just watch the mucosa lifting height to decide how much injection solution I need. Because we just use a saline, I think it's very safe.好，拿个夹子来。先把刀给我，把这个血先止住。I think there's a very small vessel bleeding here. So let me show you the DHL model again. So you will see it's very easy to find the bleeding dot. And I will use a drill knife to make a calculation. 好，刀头收着的啊，好，往前出。好，回来一下，我看看。还有，这边还有。这里。完了，go。啊，往前出一点，还往前出一点。 来看一下，这边还有一个啊。Okay. And then, oh, yeah.
It seems like the HI mode helped identify the bleeding source.
Yes. So, and now I return to the white light model. 这不是白光。对呀。哦，还要按一遍。你选这个大个架子。And then I use clip to make a traction. 哎，不要转嘛。This is just a regular clip, and to capture the border of the lesion. And then I use the try to move the lesion and then suck the air. You will see. 哎，不，不是这里。分开，你把那个夹住了。哎，好，先收着，不着急。对，夹在这个位置啊。不是，然后往上。哎呀，这个地方。好，来试着收开。OK，哎，可以的。听指挥啊，为什么要自己做主张呢？张开，收。好，可以啊。I just use the clip to capture the tissue. 就是capture the tissue of the lesion and the outside colon mucosa, and use the traction that will make the ESD procedure easier. 来，就是好，再来，好，倒给我。So the clips help me to fix the lesion to the outside colonic wall and help me to make a very clear visualization of the submucosal dissection plane. 包头出来了。 So we need to repeat submucosal injection to make sure the border between the lesion and the muscle layer.
The traction was very helpful. Guido, you do traction on a regular basis, or you have a preference to do a pocket dissection?
Yeah, I tend to do more pocket creation method. Yeah, it helps for traction. Yeah, definitely.
知道了。
Or with underwater, it helps you with traction also, doing it underwater. But I've used also clips and bands, and you have to control insufflation, because when you insufflate a lot, it tends to split, and it can tear the
出来
tissue.
高头，高回来一点，高头回来，哎呦，高
That's
整
another
个到
advantage when you do underwater. You don't need to insufflate that much. That's right.
Yeah.
高头出来了没有？好，高头收着，高头收着，收着啊。然后回来一点，太远了，哎。要回来一点点，太长了，我就镜子离得非常的远，我看不见。好，要回来太长了，你不要去调我的刀的长度啊。啊啊，好，刀头收着，这个地方要收。嗯。
Despite the very nice image to identify bleeding source, the white light image is so good that
Yes,
you
the
can see.
image. Yes, yes. 又有哪里出血了？啊，这里不管它了。啊，知道。好嘞。
You're almost done, Dr.
Yes,
Liu.
yes. So with the traction, the single clip traction method, in my center, we always use this way to help us to test the ESD procedure.
Yeah.
Oh, sure. Sure. 我先出，看见它。这边补充做点注射来。So I need to repeat some mucosal injection at this corner because of the visualization of this part is not so clear. So I want to identify the border between the lesion and the muscle layer to avoid the perforation or the muscle injury.
Dr. Liu, how do you differentiate the desmoplastic reaction from the infiltration of the muscularis propria? Because we're seeing in this case a lot of desmoplastic reaction tissue.
I'm so sorry, pardon?
Yes, how do you differentiate in the image when you have infiltration of the muscle layer compared to the desmoplastic tissue?
You will see we can use why do we mix the methylene blue into the saline cause the color you will see the muscle layer always looks a little bit white and we can see the muscle fiber there. So I think is if with the submucosal injection, I think it's not so difficult to identify it. 刀头收着，哎，然后进来。OK，刀头收着，收着，出来，回来，回来，再出，再回，好，再出，顶上去，好，收回来。OK，好，出刀。刀回来一点。哎，好。刀头收。好，出。刀头收。这个地方困难的，不要紧。 出血先告住，再来重新牵拉这个位置，这个地方可能不行，拉的我这边就看不见啊，里面进去，好，好，good，嗯，好，来一点点，嗯，会，好，没挨着，往前推一点，啊，再出，刚刚出的啊，回来，回来，再往前出一点太短了，再回一点又太多了，好吧，再往前出一点点，啊，就是。First, a part of the lesion is gravitationally downward side, so uh, it's a little bit a little bit difficult to avoid the influence of the water. Um, so that will make the ESD procedure a little bit difficult.
Yes, and this is a location where there's a lot of blood vessels, as
Yeah.
we could see. So this, yeah, it needs to be performed with a lot of patience. A doctor from the audience, Dr. Liu, Dr. Espinosa Cardenas is asking whether you've seen fibrosis in the submucosa in this resection.
I think that there's a little bit of fibrosis in the submucosal layer of this case. So I just repeat the submucosal injection and try to uh, control the endoscope to make sure we do have a very good visualization to make sure the cutting is safe. Okay. 好多手，啊，主持，啊啊 Okay. So you will see after the injection, we will find the more blood vessels and the submucosal layer, and we can make a calculation first to avoid the bleeding. 好的，再往前推一点点。往前出一点点，再往前推一点点，回来，回来，回来，回，再来，出，往前出一点点，哎，镜子有点攀，好，再回，往前推一点，到头收，出来，推，到头收着，好，到头拿出来擦一下，好，补注射来，这边，往前针往前戳一点，好好，我看一眼啊，还差一点点，来，再来，刚好是一堆血管在这儿，出，再往左边去一点点，然后把这边搞完，哎，好，发给我。 啊，出了啊，导杆往前出一点。好，再来。好，倒回来，往前出。好，再来那边搞。
So you've been able to coagulate the vessels with the knives without using the
Coagulation forceps.
the forceps. So
Yeah, I seldom use the forceps. 到头收着。I think the tip of the knife is enough. If we use the coagulation forceps, we need to pull back the knife and insert the forceps. So I think it's not so convenient. And I think the tip of the knife, you will see, the coagulation effect is good. So I don't think we need to change the instruments frequently. Okay. 放进去一点。好，再来。好，那边右边再来一点，跟回来一点。你不要杵那么长，你杵那么长我进不去。哎，对，右边还要一点，右边。对，好，不打了，点不对，好，来倒给我。猫头出了啊，然后回来点，不杵那么长我跟不进呢。猫出来呀，刀头，刚才刀头是没出来的，刀头没出来我就没有办法那个的了。等一下，等一下啊。好，来出。嗯，哦，稍微回来一点点。哎，对。喂。 往前推一点点啊。
Dr. Liu, I'm seeing that you're sitting. You're not standing up. You usually do just your ESD sitting?
Yes, because I if I'm a lady, so 再回来一点点，哎。So I think sometimes the ESC procedure will cost maybe 2 to 3 or 4 to 5 hours. I think it's very difficult for me to stand for so long time. So I always sit.
Great.
这还插水，我要切错了。好，出。啊，再出来，你看看我要不要再拉一下？不多了以后它就不用了。我看一下啊，好，拿个夹子来。I almost done, but I think the traction strength is not enough for me at this condition, so I will use another clip to perform a second clip traction. 好，你把这个，我先夹这边看看啊。好，赶着往前推一下，看看有没有帮助。有帮助，有帮助。杆回来一点点，让我跟进一下。好，你再往前，哎，收，好，不动啊，把它往前推，我镜子推一点，我看一下。哎，对，我看一下张力，你推，你只管推，我镜子要推。好，打吧。Okay. So with the help of second clip,
Yeah, you got a beautiful exposure of the
yes,
submucosa.
yes. 真出不来吗？出一下。So I think the single clip traction method is very useful because especially for this kind of large lesion. At the beginning, the first clip traction method helped us is very helpful, but uh, right now it's not enough. So we can use the second, or third, or fourth. Sometimes I use the fifth or sixth single clip traction for some super large lesion. 那边也好一点。知道。我们应该再往右边偏一点，太靠左了，是不是？嗯嗯然后还是稍微回来一点，来让我更近一点。然后稍微
There's a
出去一点。
question.
啊哈。
There's a question from the audience regarding traction methods. What's your opinion on these devices like track motion?
Usually, for the large lesion, I just perform the circumferential mucosa dissection, and then after that, I will use the gravity downward side to grasp the mucosa first, and move to the gravity upward side to fix the lesion. So you will see this case. This part is the gravity downward side. So at the beginning, I use the clip to grab the lesion of this side and move to the gravity upward side. You will see a very good effect of lifting. So I think sometimes we will choose the motion or direction, depends on depends on the lesion location. 出道，不管它，出道，出道，出，出完怎么叫唤呢？回一点，回多了再出一点点啊。欢迎你嘛，你瞎叫唤，本来不叫唤的，怎么突然瞎叫唤了？来，不管了，来出刀，来出刀。回，回一点，太长了。哎，再来。应该就是这一点了。 Okay, I'm done. 好，拿右前来。
Beautiful. Congratulations, Dr. Liu.
Thank you, thank you.
Very nice
And-
procedure.
And next step, I will withdraw the clip and move the lesion out of the body. Just wait a minute. 好，您太假来看我巴巴的住了。
What do you usually use to detach the clips?
Detach. Sometimes we can use the regular clip.
Mm-hmm.
我们先来加这个。没有油了，我是说我怎么那么费劲呢吧？推屁股推不动。我是说我怎么那么费劲啊？ I used another clip to grab the fixing clip and just pull it back softly. Okay, 再来。好，抓紧。OK， 好，松开。再来。
Beautiful.
抓紧。使劲儿。 Okay. So this is the specimen, and we will fix the specimen. You 先把透明帽子先给我取下来，镜头给我擦一下。There's a little bit bleeding, but it will stop spontaneously. So don't worry about the bleeding. So this is the second location of the traction clip, and this is the first one. You will see the bleeding
Yeah.
is stopped already.
It's tapped already. Yeah.
So I think
Very nice.
yes.
This is a beautiful image.
So
Very nice procedure.
thank you very much. 刀头，刀给我。So regularly I will use the knife to calculate the small vessels that I think there's a possibility of bleeding after ESD. So I will double check.
Do you keep the patient at the hospital or you discharge the patient the same day?
Regularly, this kind of patient, we will keep them in a hospital. We will 知道. For this kind of patient, we will observe 48 hours or 72 hours. After that, we will discharge the patient. I think here is a very small artery here. So although there's no bleeding right now, I think it's very necessary to double calculate the vessel again, because the vessel, we still can see the parts of the vessel.
Do you ever consider clipping those types of pulsating vessels?
Yes. So 要回来一点点. For each case, I will spend 5 to 10 minutes to double check whether there's a possibility of bleeding or perforation. 好，把帽子给我戴一下吧。就给我扔了啊？帽子给我扔哪去了？哦
Do you prescribe these kind of patients stool softener for a couple of days or not?
I pardon?
The softeners, stool softener.
Oh, no. We just keep the patient in hospital, and maybe we will ask patient to drink or eat softer foods maybe tomorrow, and the patient symptom will have the stool in 72 hours. So I think it's very safe.
And a question from the audience: what's your opinion on this hemostatic peptides like Puristat applied on the resection bed?
I think this is uh, adenoma with hyperplasia. Maybe part of them, I think is in the middle part. I think maybe it's around this area. The surface of the lesion looks more red, and so I think the hyperplasia. I think is. I, I I agree with him. Okay, this is a vessel. This is a vessel there. but I don't think I need to calculate. It's safe. So I think I don't need to do more for this case. The procedure is done.
Perfect. Thanks so much, Dr. Liu, for that impressive live demonstration. Now let's open our final interactive Q&A session. If any of our guests, viewers have clinical questions, please, it's the time to do so. Technical inquiries, topics for academic discussion, please feel free to raise them. Our expert panel is delighted to address your questions. So you've answered a few of the questions from the audience. There's one more one.
Okay, let me show you the specimen. It's around 5.5 plus 6 centimeter. So we plus there's enough normal mucosa we cutting, so we can use the fix and find the specimen very well. You will see. Okay.
Very nice. There's a last question from the audience. What happens with the tissue, with the remnant tissue?
You mean how to handle the specimen after the ESD?
I'm not quite sure about this question, to be honest. I don't know what they mean with the remnant tissue.
Usually, you will see we will fix the tissue on the plate, and after that, we will put the tissue in the formalin for 24 hours. After that, we will cut the tissue by ourselves, not by the pathologist, uh, into the small one. It's around 4 millimeter. Wide width is 4 millimeter. And after that, we will send every tissue to the bottom of pathology, and we were waiting for uh, the pathologist report.
Great.
That's interesting. You cut the tissue by yourself. How do you do that? Can you explain us?
Spray?
I mean, you said you cut the tissue yourself.
No, by nurse.
Okay.
Sorry, I don't have enough time to send the tissue by myself. You know, China is a very huge population a nation, so every day we do have many patients. So for this kind of ESTP procedure in my center every day, almost 6 to 10 cases per day.
Wow, that's amazing.
Maybe the previous question was about the resection base, the resection bed. Do you ever close it, Dr. Liu?
No, but we will treat the specimen in a single room.
Okay.
We don't have the closet, but the closet is in the department of pathology.
Great. Well, Peter, I don't know if it's time to close the session.
I think since we have finished procedure, there's no questions. I think could be go into the ending section. How do you think?
Yeah. Yeah, thanks again, Dr. Eliu. Thank you all for your enthusiastic participation and excellent interaction. I would like to express heartfelt gratitude to first Dr. Ketron Chen and Dr. Meliu for their professional presentations and impressive surgical demonstrations, Dr. Alberto Baptista for his valuable insights and academic contributions, the Mexican Endoscopy Association, AMEC, for their generous support of this event, Linmo Medical for providing advanced endoscopic technology and professional support. Finally, thank you all, our viewers, for your active participation. We hope today's content has been valuable for your clinical practice and academic research. And let's look forward to our next gathering. Wishing you all success in your work. Have a good night.